Hi everyone, welcome to my channel. In this video, we are going to learn about clinical anatomy of scalp. Let's see in brief about scalp. Scalp is a soft tissue covering the vault of the skull. It is a soft tissue covering the vault of the skull. It consists of 5 layers from superficial to deep: skin, connective tissue layer, aponeurotic layer, loose areolar tissue, and pericranium. You can remember the layers by using the mnemonic scalp. S. Skin. C. Connective tissue layer. A. Aponeurotic layer. L. Loose areolar tissue. P. Pericranium. The skin consists of numerous hair follicles, sebaceous glands, and sweat glands. The second layer is connective tissue layer. It is made of dense connective tissue. The blood vessels and nerves of the scalp lie in this layer. You can see here the blood vessels and nerves of the scalp lie in this layer. Aponeurotic layer, it consists of epicranial aponeurosis and occipitofrontalis muscle. Epicranial aponeurosis and occipitofrontalis muscle. Occipitofrontalis muscle consists of two occipital bellies and two frontal bellies. The fourth layer is loose areolar tissue. It consists of loose areolar tissue. Imaginary veins passes through this layer. Next is pericranium. Pericranium is the periosteum of the skull. Now let's see the applied aspects of the scalp. Sebaceous cyst. The scalp has numerous sebaceous glands. Hence it is a common site for sebaceous cyst. As the scalp consists of numerous sebaceous glands, it is common site for sebaceous cyst. Surgical layers of the scalp. The first 3 layers of the scalp: skin, connective tissue layer, and aponeurotic layer, are adhere to each other and they cannot be separated surgically. They are adhere to each other and cannot be separated surgically. The connective tissue layer firmly adheres the skin with the underlying aponeurotic layer. These 3 layers cannot be separated surgically. Hence, they are called surgical layers of the scalp. These layers form the scalp proper. Wounds of scalp bleed profusely. The wounds of scalp bleed profusely for the following 2 reasons. The scalp is richly supplied by arteries. 10 arteries which anastomose freely with each other. The scalp is supplied by 10 arteries, 5 on one side and 5 on other side. The walls of the vessels are adherent to the fibrous network of the dense connective tissue layer. We know that the blood vessels of the scalp lie in the second layer. The walls of these vessels adherent to the fibrous network of the dense connective tissue. Hence, when the blood vessels are torn or cut during injury, they are unable to retract, causing profuse bleeding. As the walls of the vessels are adherent to the connective tissue, they are unable to retract, causing profuse bleeding. To stop this bleeding, apply pressure on the bleeding vessels against the skull bone. We need to apply the pressure against the skull bone to stop bleeding. The wounds of the scalp heal quickly due to high vascularity. Black eye. A blow on the head often produces a black eye few days after the injury. Blow on the head produces black eye few days after the injury. A blow on the head leads to bleeding into the layer of loose areolar tissue. A blow on the head leads to bleeding in the layer of loose areolar tissue into the fourth layer of the scalp. Laterally, epicranial aponeurosis is attached to zygomatic arches via temporal fascia. There is bleeding into the fourth layer of the scalp into the loose areolar tissue. Laterally, epicranial aponeurosis is attached to temporal lines. Via the temporal fascia, it is attached to zygomatic arches. There is temporal muscle. Over the temporal muscle, there is temporal fascia. The temporal fascia is attached to zygomatic arch. So laterally, the epicranial aponeurosis via the temporal fascia is attached to zygomatic arches. Posteriorly, epicranial aponeurosis and occipital bellies are attached to external occipital protuberance and superior nuchal lines. Posteriorly, the epicranial aponeurosis and occipital bellies are attached to external occipital protuberance and superior nuchal lines. So laterally and posteriorly they are attached to the bones, but anteriorly the frontal bellies have no bony attachments. Anteriorly, the frontal belly has no bony attachments. Frontal bellies merge with the skin and subcutaneous tissue of the eyebrow and root of the nose. Frontal bellies merge with the skin and subcutaneous tissue of the eyebrows and the root of the nose. Hence, there is no bony attachment anteriorly. Therefore, the blood from the loose areolar tissue layer may spread posteriorly up to the superior nuchal lines, sidewards up to the zygomatic arches only. Anteriorly, the blood tracks down underneath the frontal bellies and appears first in the upper eyelid and then the lower eyelid over the course of a couple of days. As laterally epicranial aponeurosis is attached to zygomatic arches, the blood in the loose areolar tissue layer extends sidewards up to the zygomatic arches. As posteriorly, the epicranial aponeurosis and occipital bellies extend up to the external occipital protuberance and superior nuchal lines. The blood extends up to the superior nuchal lines. As anteriorly, the frontal bellies have no bony attachment. Anteriorly, the blood in the loose areolar tissue layer freely tackles down underneath the frontal bellies and appears first in the upper eyelid, then in the lower eyelid over the course of couple of days. This causes a black discoloration of the skin around the eyes, a condition called black eye. Blow on the head is one of the cause for black eye. Dangerous layer of the scalp. The fourth layer of the scalp, loose areolar tissue, is called dangerous layer of the scalp because pus or blood tend to collect freely in this layer. Pus or blood tend to collect freely in this layer. Further infection from this layer can be transmitted to the intracranial dural venous sinuses through valvulus emissory veins. For example, there is pus in this layer. Infection from this layer can spread to intracranial dural venous sinuses through the emissory veins. For this reason, it is known as dangerous area of the scalp. Gaping wound of scalp. If the epicranial aponeurosis is divided transversely, the wound of the scalp gape. The epicranial aponeurosis is under tension in the anterior-posterior direction. If the epicranial aponeurosis is cut transversely, then the gaping of wound occurs. Safety valve hematoma. Fractures of cranial vault may be associated with tearing of dura mater and pericranium. This is cranial vault. Above the cranial vault, there is pericranium. Below the cranial vault, there is dura mater. When there is fracture of cranial vault, it may be associated with tearing of pericranium and tearing of dura mater. In such cases, blood from intracranial hemorrhage enters the subaponeurotic space of scalp through the fracture line. Through the fracture line, blood from the intracranial hemorrhage enters the subaponeurotic space of the scalp. This is aponeurotic layer. Below the aponeurotic layer, there is subaponeurotic space of the scalp. The blood enters the subaponeurotic space of the scalp. The signs of cerebral compression do not develop until the subaponeurotic space is fully filled with blood. Unless the subaponeurotic space is fully filled with blood, the signs of cerebral compression do not appear. For this reason, collection of blood in the fourth layer is called safety valve hematoma. As the signs of cerebral compression do not develop until the subaponeurotic space is filled fully with the blood, it is called safety valve hematoma. Cephalohematoma is subperiosteal collection of the blood. Below the periosteum, there is collection of blood. As the periosteum is firmly adherent at the sutures, the collection of blood takes the shape of a particular bone. If there is collection of blood under the periosteum of the particular bone, then the blood cannot accumulate in the subperiosteal region of the other bone because the periosteum is firmly adherent at the sutures. Hence, the blood cannot move across the sutures. Cephalohematoma commonly occurs in the parietal region. Caput succedaneum. It is subcutaneous edema of the scalp produced during delivery. It is subcutaneous edema of the scalp produced during delivery. It occurs due to interference in the venous return during the passage of the head through the birth canal. Due to interference in the venous return, there is increased hydrostatic pressure within these veins, causing fluid leakage. Thus, there is subcutaneous edema of the scalp. Let us revise the applied aspects. Sebaceous cyst, it is the common site for sebaceous cyst. Surgical layers of the scalp. First three layers of the scalp are called surgical layers of the scalp. Black eye. Blow on the head leads to accumulation of blood in the loose areolar tissue. The blood trickles down anterior and accumulates in the eyelids. Dangerous layer of the scalp. Fourth layer of the scalp is called dangerous layer of the scalp because infection from this layer can spread to the intracranial dural venous sinuses through emissory veins. Wound gaping. If the epicranial aponeurosis is cut transversely, then there is gaping of wounds. The wounds of scalp heal quickly due to high vascularity. Wounds of scalp bleed profusely. Safety valve hematoma. The signs of cerebral compression do not appear until the subaponeurotic space is completely filled with the blood. Cephalohematoma, subperiosteal collection of blood, commonly seen in parietal regions. Caput succedaneum, it is subcutaneous edema of the scalp, occurs during delivery.